Okay. Okay. Welcome to the webinar today. This is going to be about fall prevention and can you prevent falls? So, I will tell you a little bit about myself. My name's Amber Steckel, and I am a physical therapist who I've been a physical therapist for about 11 years now, and I've become more and more interested in the idea of fall prevention. I've worked in most every setting, outpatient orthopedics, I've worked in a hospital, skilled nursing, acute inpatient rehab, home health, and now I do mobile physical therapy in Central Florida, which is with outpatients with those who have Medicare. And I love that because I get to see people in their natural environment, in their home. It's very convenient for people. And I've really, really gotten interested in the idea of fall prevention and balance. And so I do workshops locally and teach about balance and fall prevention. And I do an 8-week course on balance and fall prevention, which has a teaching component and an exercise component. And that's a very comprehensive class about the idea of fall prevention that can really, really help people to be empowered. That's my favorite thing is empowering people. There's so many myths around balance, and we're going to get into that in a moment. That I love to dispel these myths. I love to help people see more confidence in themselves and in their abilities. And that's just so exciting to me, so rewarding is to kind of coach some people who have maybe not had the best experience with physical therapy, or maybe say they've had like a very mediocre experience, and teaching them a lot of these concepts. I've seen a lot of success and improvements in their abilities and their confidence, which is really awesome. So we will get started today. I'm gonna start the webinar and share my screen. I'm already sharing. I'm gonna play the slideshow. There we go. And this is my very first webinar ever, so that's exciting. So bear with me as I figure out how to do it from this end. So today we're going to talk about truth and myth about balance. So we'll go through a number of items. You'll just talk about if you think it's true or false. And then we're going to talk about fall risk factors and what goes into increasing or decreasing your fall risk. And then lastly, what can you do about it? And there's two number twos there. Okay. Mary, I am going to go ahead and unmute you. I don't think it's letting me. There we go.
Can
All
you
right.
hear me?
I can. Okay.
The volume is just a bit low. Is there any way to?
Is the volume turned up on your end?
Yeah,
Yeah. Audio. How is it now? Is that any better, worse, or the same?
it's about the same.
About the same. Mm.
It's okay. Just continue. I just thought I'd ask if there was.
There it goes. Phone audio settings. How is it now?
I go up and down the bar, but it's about the same.
Oh, okay. You know what? This has happened. I don't know. I'll have to look into it after we're done with the webinar.
Okay.
Okay, sorry about that. Can you hear me?
I can. I just have to listen very carefully.
Okay. Okay, bummer. All right. Well, I'll try to speak loudly. Okay, so if you're up for it, I'll ask you to play along with the Mythbusters game here. So You probably already know the answer to all of these actually. Um, Most people fall inside as opposed to outside.
True.
Yes, that is true. That is true. Do you happen to know that bonus points for do you happen to know the most common room in the house that people tend to fall?
The bathroom.
Yep, ding ding ding. You got it. Declining balance is a normal part of getting older.
Myth.
So that is a trick question.
That
That
is
is
true.
true.
Okay.
So physiologically, science-wise, we do actually have a decrease in our balance as we get older. Declining strength is a normal part of getting older.
True.
That would be true. Falling more often is a normal part of getting older.
True.
That's another trick question. That one
Myth.
is
Yeah.
false. Yes. So as we get older, we do have a natural decline in our strength and balance, but it is not normal for people to be falling more. So here's where I like to add the caveat that falling to an extent happens in life, right? We've all fallen down at one point or another. I've fallen jogging, I've fallen walking upstairs. I know it, you're going to fall sometimes, but it should be very few and far between. It should be an accident, a freak thing. And it really honestly should be about that same way as we're getting older. So when I ask people, when's the last time you've fallen? I really love when they have to scratch their heads and say, oh, maybe about 3 years ago, I had this weird accident. And so that's always a good sign. It's just that it's very common in our culture and in our world, really, internationally too, that falls have, there's a perception that it is a normal thing. Okay, next, walking 150 minutes a week is effective at preventing falls in older adults.
Myth.
Correct. That is a trick question. Walking alone doesn't prevent falls. Really, we need to be doing some sort of strength training. So that's where the little trick was there. Okay, most people fall while moving as opposed to standing still.
Truth.
True. Yep. Good job. After a certain age, you cannot improve your balance.
I'll be positive and say myth.
Good. Yes, that's correct. You can improve your balance at any age, really at any age, aside from a couple neurological degenerative diseases. Really, by and large, most people any age can improve their balance. After a certain age, you can improve your strength.
Myth.
Cannot improve your strength.
Myth.
Yeah, yeah, it is a myth. Okay, and most falls cannot be prevented.
That's a tricky one. Myth.
Most falls cannot be prevented. Correct. That's a myth. Yep. I would argue that some falls cannot be prevented. Most can. And that would be with education and really just forethought. So planning and coming up with strategies and supporting yourself with what you need. So a lot of that starts off with education. So, by taking fall prevention classes, that can really decrease your fall risk because it's such a broad topic and there's a lot of different components, as we'll see, that can increase or decrease your fall risk. Okay. Bone density is the most important risk factor that determines if someone who falls has a fracture or not.
True.
So that is false. And bone density is one of the most important risk factors, but another one of the most important risk factors, if not in some cases the most important risk factor, is the direction that you land
Yeah. The
and
the
if you're sitting or standing when you fall. So most fractures happen when people fall from a standing position as opposed to a seated position. And then the other thing is if you fall a little bit to the side and a little bit back, so if you kind of fall diagonally backwards, that's your most likely risk to get a hip fracture. Um, if you fall forward and your arms are completely outstretched and they're locked out and you fall really hard on your wrists, you're really likely to get a wrist fracture there. So a lot of it has to do with the mechanics. So learning how to fall can actually be very beneficial. And there are training exercises that some of them don't even require you to get on the floor that can train your body for, I don't want to say tuck and roll, although that is a good method. Um, but that could be one method. But they train you to, for example, land on your forearms and turn your head when you brace, when you land, so that you don't get a wrist fracture and you don't get, break your nose kind of thing. So, the direction that you land is really important. Okay, I don't have any balance is a valid statement.
Myth.
Correct. Correct. So, this is just a very frequent statement that I hear a lot. Some people are just trying to exaggerate for comedic effect, and some people really don't think that they have any balance. And so I just like to tell people, well, you might have a little bit of balance. You might not have a lot of it, but you do have some level of balance. Or maybe if we're doing a rating scale, we could say, "Oh, my balance is terrible." That would be a more valid statement than "I don't have any balance." Reporting a fall to my doctor will lead to a restriction of my independence.
Myth.
Yes, this should be a myth. I've heard a lot of my patients and a lot of cases where it can lead to a restriction of independence, but it really shouldn't. It should lead to more independence, and it should be an open conversation of, okay, how can we support you in the best way possible so that you don't fall again. Whether it's, okay, let's walk with a walking aid for a little bit, or let's take a fall prevention class, or let's get you to a physical therapist and get you stronger or something like that. But this is a really big fear in those that do fall. The other fear is fear of telling your family can lead to a restriction of the independence, but the ideal case and what my mission in what I do every day is trying to create uh, healthcare and a healthcare team that's really supportive, and that it would lead to an increase in independence or maintaining the same level of independence. Okay, next, sliding or tripping is not a fall.
This sounds tricky, but I think myth, because I think you had said at one point to it's like a warning, like a red flag.
Okay. So I'm going to say that sliding and tripping are falls. So this could be semantics, but also, um, what's the other one I hear a lot? Slipping, tripping, sliding. Um, so a fall is any unintentional change in position to a lower level. So I hear this statement all the time, and I was very confused for a long time, and now I've started asking people, and so what they're calling a trip would be, say I'm walking into the grocery store and I trip over a parking curb. Well, I didn't just lose my balance and fall, so it's not my balance that caused me a fall, so that's not really a fall. I fell for a good reason. There was a curb in the way, and I tripped my foot over the curb and fell. Um, and then I come in and say, well, if you had been, more focused on where you were walking, if you had better strength in your legs, if you had better reaction time and could, better balance, would you have still fallen? And they'll say, well, maybe not. So those are some of the things that um, I would vote that this does count as a fall. Technically, in some circles, a fall could even be so much as you attempt to stand up and you lose your balance and you fall back down to the chair because really your intent was to rise and you didn't. You fell back in the chair. So that could be categorized as a fall. Also, sliding off the edge of the bed. Really, you were hoping to not do that. And so, if you had been stronger, could you maybe have stayed on the edge of the bed? So those are examples that so sliding and tripping, us physical therapists do classify as a fall and the healthcare system, I would say. Okay, the more medicine you take, the higher at risk you are of falling.
True.
This is an asterisk. So I'm going to say false. And the reason is it depends on the type of medication.
Yeah.
So in the past, they used to say if you're taking 5 or more medications, you're at higher risk of falling. So this used to be true. And now they've done research on what's called fall risk increasing drugs. The little acronym is FRIDS, FRIDS. And so if you're taking 2 or more FRIDS, then you're at higher risk of falling. So if someone's taking 7 medications, 2 of them are FRIDS, the rest are not, then they would still be at increased risk of falling. Or say they're only taking 2, there we go. If they're only taking 2 medications, but they're both fall risk increasing drugs, then they're at higher risk of falling because of the medications. I do recommend that everyone get a medication review from your pharmacist and or your primary care and or if you follow with a specialist such as a cardiologist. That I like the more opinions the better because they're all coming at it from a different lens and a different background and experience level. So what you can ask them is, hey, have you ever heard about fall risk increasing drugs? And I can send you the link for that too. That's like a research article that you can print out and bring to them. There's also another good reference is the Beers criteria, for which essentially is criteria for trying to reduce medications as much as possible in older adults, trying to reduce redundancies, stuff like that. So you can bring them and have them look at it and try to, if they can't eliminate it, can they reduce any of the doses? Or can they give you instructions on, are there any natural ways that I can get off some of these? So most of those fall risk increasing drugs will either cause drowsiness, lightheadedness or dizziness, big fluctuations in your blood pressure. So hypertensive medications are one of them and things like that. Okay. Almost done here. Everyone over 65 years old needs to do balance training, even if they don't have a balance impairment.
Myth.
Correct. So really, everyone needs to be doing strength training. That is going to do the bulk of improving your balance. But research has shown you only need to do balance training specifically if you have a true balance impairment. So I used to practice a lot more doing balance training, and then I learned this and realized that I needed to put most of my emphasis on strength training with only sprinkling in balance training, and that gets most of the results. So, okay, lastly, fear of falling has mental and emotional effects, but does not physically increase your fall risk.
Myth.
Correct. Correct. Fear of falling is a fall risk factor. It does increase your risk of falling. Okay. So now we're going to talk about fall risk factors. So this is one of the resources that I'm going to email you guys. And the fall risk factors, so there's dozens and dozens, long list of things that can increase or decrease your risk of falling. This is the most easy to understand way to categorize that I have found. So we have internal, external, and behavioral factors. So internal I'm gonna see if I can flip over to my worksheet here. There we go. Oops. Okay, so we're going to focus on the internal right now. So this is things that are within your body. So age, we talked about. Naturally, as we get older, our balance and strength kind of declines. So we could be at a higher fall risk. Um, Chronic illnesses, Parkinson's, something neurological, arthritis, just people that have pain from arthritis can be a chronic thing, cardiovascular disease, diabetes, any long-term illness like that, depression and mental health, that can affect your mood, your outlook. You almost get kind of just absorbed in, I don't want to say tunnel vision, but you're not as aware sometimes, and so that can affect your fall risk, your vision, your cognition, your body strength. So if you have any weakness or frailty, that would definitely increase your risk of falling. A balance impairment, that goes with coordination, kind of, and any difficulty, a gait abnormality. So that could be foot drop or a problem with a hip or knee that really causes you to limp. Um, or something in your back too that causes you to really stoop over, that will change your sense of upright. And then uh pelvic health, so this is a lot of times if you happen to have urinary incontinence and you're running to the bathroom a lot and you're rushing, you could be at a higher fall risk for that time. Fear of falling, we touched on that. And then dizziness, lightheadedness. So there's a lot more not listed, but that is the general gist of internal risk factors that increase or decrease your risk of falling. A lot of these we have control over, and some we don't. So, say you have heart disease. I had a guy that fell playing pickleball and he had a heart attack on the court. And could he have prevented that fall? No. But after the fall, what he does have control over is really being on top of his cardiac health, following up with doctors as recommended, taking whatever medications they prescribe, lifestyle changes, like they might be recommending nutrition, diet changes, or exercise changes. So, that he had control over. If someone's diagnosed with Parkinson's, can they change that? No. But they can control how they manage the disease to an extent. They can control if they continue exercising. They can continue working with therapists and stuff like that. So, the goal here is to find as many things that we can do something about. So, external risk factors, assistive devices would be a walker, a cane, a walking stick, which is my favorite walking device, is a walking stick. I love that. It keeps you in a good upright posture. But sometimes you can kick them with your feet or they get sometimes they actually get in the way, right? So then hazards around the home, this could be rugs, infamous rugs. We all love them, but they're a very high fall risk. So get rid of all your rugs or as many as you possibly are willing to get rid of. Um, if there's anything, if the building is damaged, if the sidewalks are damaged around your house in your neighborhood, if there's slippery floors, if the stairs are, depending on if they're carpet or wooden, they might be easier or more difficult for you to walk on. Insufficient lighting, that's a big one that I've learned more and more over the years is has a huge impact, especially because a lot of people fall in the middle of the night going to the bathroom, but even during the day. So lighting solutions can be a game changer. Pets and people bumping into you out in the community, that's very unexpected. Weather, And then we start to get into kind of more macro ideas like decreased social support. So if you have a caregiver with you 24/7 and you have balance issues, you're going to be much less likely to fall than if you don't have a caregiver, right? If you have um, people that can help take you to your doctor's appointment and walk you in, for example. So, social support, if you have a buddy that you can even do an exercise with, like somebody from my last round of the fall prevention class, two of them actually started working out together once a week. So, that was an example of good social support. So, they were fully independent, both of them are driving, but they still socialized out in the community, and then they found a way to continue exercising together that they probably wouldn't have individually. So that's another example. Lack of community resources. So this largely depends on the city that you live in. Here in Orlando, thankfully, we have a lot of community resources, um, you know, access to good health care, good hospitals, stuff like that. Decreased income and education level, limited access to health and social services, transportation barriers, inadequate housing situations. So these are kind of those more macro ideas where if you don't have money and transportation to get to your physical therapist, or say you don't have a health insurance plan that gets you more than 10 visits and you need ongoing therapy for a while, then that's going to increase your fall risk and kind of put you at a higher fall risk. Okay, lastly, here we have behavioral. Hoping that there we go. So these come down to a lot of decisions, choices that we make. And a lot of these are lifestyle choices too. So medications, you have the people that are like, I am anti-medication. I don't want to put anything in my body if I don't have to. And then I have a lot of patients that just, they don't have a medical background. So of course, if you go to the doctor and they recommend that you take a medication, you're going to take it. But sometimes all the doctors don't communicate between each other. So then they end up with all these medications on their list and they really just don't know any better because they were told to do that. So they think they're doing a good thing by taking all of them. Um, so that footwear, this is very individual. I like to promote closed-toed shoes. So it could be lace up, it could be slip-ons, but closed-toed shoes generally are going to be the most supportive. Excess alcohol and drug intake, lack of physical activity, nutrition, hydration. How much water are you drinking? Are you getting outside every day? Are you sleeping good? If we're all foggy when we get a bad night's sleep, or if you have chronic sleep issues, that's going to really affect your energy and definitely increase your fall risk. Multitasking, that one's I'm still working on that one and moving too quickly. So we in our culture kind of see multitasking as a badge of honor, but it really can increase your fall risk and make you distracted and moving too quickly. So if you're running late or rushing, doing a risky task by yourself instead of asking for help, and then not following your healthcare provider's recommendations. I do recommend to everyone, if you have a fall, report it to your doctor, report it to your family, report it to your physical therapist if you have one. And if you have more than one fall, that's not an accident, I would always recommend to begin therapy right away. Like as soon as possible, the sooner the better, just to get that one-on-one evaluation. So that is the different risk factors. And now we're going to go on to the fall log. So this is the other resource that I hand out to all my patients. And I'm going to email you guys a copy of this as well for you to print out. But you can also just, if you have a notebook, you can just make your own, really. Just the categories are what's important. So Um, let me see. I'm going to ask you to unmute, Mary. Okay. Do you have an example that you would like to share of a fall, or would you like me to use an example that came from a random anonymous patient?
I can give you an example if you like.
Okay. It's totally up to you. I have plenty of examples to draw from, but if you kind of want to work through one, then we could do that here.
When sometimes if you like it, use it. If you want to use one of yours, it's fine. My mom, when she sits in her like her lounge chair, she tends to slide down, and
Okay.
then sometimes, like a few times, she actually ends up on the floor.
Okay. Let's use one of those. And can you see my fall log screen here?
Yes.
Okay, great. So, when was the last time that she slid onto the floor?
Oh, a couple of months ago.
Okay. So, for this, if you know the date, we can be very specific. Like, say it had just happened Saturday, then we could put the date here and like the approximate time. But this is really just a guide. So we'll say September, August, July.
Okay.
So we'll just say July 2024. Do you remember if it was morning or night?
Night.
Okay. You know about what time?
Oh, about six p.m.
Okay. Let's put 6 p.m. And then, so say it again. She slid onto the floor from her recliner chair.
Yeah.
Okay. Um, Mom slid onto floor recliner chair. And did you say she was leaning for a while, or what had she been up for like a long time, hours and hours, or why was she slipping in the first
She
place?
had been up, I think it might be a week, like a week core or something. Like she always tends to slide down kind of.
Okay, always tends to slide down. Okay. Okay. All right. That's perfect. So, um the purpose of a fall log before I go too much further is number 1, to see all the things that we can control, and we can feel very empowered about that, and we can actually take action. Number 2, it's helpful to identify trends. So I have some people that come to me and they say, "Oh, I've fallen 3 times recently." So we go through the three times that they've fallen very in depth and see, are there any patterns. Um, and then number 3, it's just for keeping the facts straight, because humans, we don't really have all the best memory, not just as we get older, but anytime. We don't have a better way to say it is we don't have a good perception of time. So a lot of times when I think something was like 3 months ago, it really was 6 months ago. So this is just to keep the facts straight, and so that if you do start falling more frequently, then you can just go back and you have the data right here. Okay, so when we get to the root cause list, so the fall log is kind of broken up into the description of the fall. What are all the risk factors that we think might have put us at risk and might have caused that fall? And then we can say, I think it was mainly these 2 things. And then, can anything be done differently in the future? Are there any factors within my control? So we will look at, let's just pull it up here. So with your mom, Mary, what of the internal risk factors do you think put her at risk of falling when she slides onto the floor?
I think some of it might be like a strength issue.
Okay, I agree. Strength, and you already said core strength,
Yes.
and maybe full body, maybe core, maybe all of it. Okay, what
Mm-hmm.
else? Do you
Um,
see any here? So age, how old is she?
she's 88.
88. So maybe age. What about any chronic illnesses that could have put her at risk? Does she have a, this could be like a toe or a foot or a leg amputation. Um, that could be another one in that category. Diabetes,
She has some cognitive impairment.
cognitive impairment. Okay. Okay. Okay.
And
Balance.
she does have like some, when she has to go to the bathroom, it's like an urgency.
Okay. Urgency. How's her balance?
Um, some issues, not 100%.
Okay. How's her walking?
She does need to be monitored. She needs to be watched.
Okay. So we'll just say balance and gait. So um, that would be internal. Then we would go down to external. So she's sitting in the chair, she's sliding down. So external examples would be like, how is the chair? Is it a crazy chair that puts her at an angle that makes her more likely to fall out? Is it a recliner? Like, for example, okay, this a recliner chair do you have an electronic recliner chair?
Yes.
Okay. If it's ever left in the upright, like a more upright position, that would obviously put her at a higher risk of sliding. So that's what I mean by that. So is the chair positioned in a good, safe way?
Yes.
Okay. Is another example I've seen, I had a woman that wore like those muumuu dresses that are like really silky?
Yes. And
So she
long.
Yes, and so they got tangled between her legs and she would always slide everywhere. So that could be another example of external. It could be lighting, if she's just sitting there, how's the lighting where she sits?
It's okay, but it's a little dark. Could be better.
Okay. We're kind of grasping here, but lighting
And
could
she
be
does
better.
have a walker, but she doesn't like to use it. So
Okay. Well, that's good to know. That's good to know for if she had any falls while walking, but with the fall log, we're going to take it case by case. So when we do the root cause analysis, we are thinking of only this time
only this. Okay.
where she was sitting in a recliner chair and slid onto the floor. Now, if we want to, we could also do just like a general fall risk assessment and say, oh, the lighting in your house needs to be better. Oh, your mom needs to use her walker as recommended. Like, so we can do a general fall risk assessment, but with this log, it's intended to do a case by case. But if you want to just use this list and circle every one that your mom has, then that could be helpful too.
Okay.
So,
We can stick to this specific one.
okay. Her clothing wasn't slippery.
No.
Okay, another one could be, how is her footwear during the day when she's sitting in the chair? Is she wearing socks, shoes, barefoot?
She hates socks. She's usually barefoot.
Okay, barefoot. So, would she be able does she feel that she's slipping?
Yes. Yes.
She does. Does she have the impulse to reposition herself?
Well, no, she gets sometimes she'll get kind of stuck. So a therapist showed me like if I put a towel, if I have her sitting on a towel, sometimes I can pull her up a little bit with a towel.
Okay, okay, cool. So she'll notice that she needs to reposition herself, she just doesn't have the strength to?
Exactly.
Okay. So in this case, then we could think about, again, we're still in the mindset of what is anything external that we could do something differently about? So, say she's really slid down. could you put a really supportive shoe on and then get maybe a 4 or 6 or 8 inch step stool, whatever. It depends on how tall your mom is, but and the size of the chair. But um, if she had really good shoes with good traction on the soles and then had a step stool that brought the ground up to her and was instructed in the proper motions, she could push on the armrest and you guys could count together. Okay, mom, we're going to scoot back on three. 1, 2, 3. And then you pull on the towel as she's also efforting to
Sure.
scoot back.
That's a good suggestion.
Okay, so we could say, um, well, that I'm kind of getting ahead of myself. We'll save that for the next column. But barefoot is definitely a risk factor. Um, okay, and then she has you. So I would say has a care like having a caregiver is putting her at decreased risk of falling. So um that would be in the good column. We're kind of trying to see what the negative um risk factors are that are increasing her fall risk here. So then let's go on to behavioral. So do you see anything here? So we did talk about footwear. I guess that's kind of redundant there, but that can some of these probably could be in a couple categories. Um, do you see anything lack of physical activity? Is she pretty
Yeah, probably not enough physical activity, like more physical activity would definitely help.
okay? What about her? She have a good appetite and drink a
Yes,
lot of water?
appetite is great.
Okay. She drank a lot of water.
I have to offer it. I have to always offer the fluids.
Okay. So maybe hydration is an issue. Then what else? Medications. Is she on many medications that make
No,
her
only
dizzy or
two really.
drowsy? What's
Hmm?
that?
No, only two meds.
Only 2 meds. Do they make her dizzy or drowsy?
And I don't think so.
Don't think so. Okay. And then multitasking. Yeah. Okay. Anything that the therapists that have worked with her have recommended that or the doctor have recommended as far as this specific incidence of like sliding out of a chair?
Just the idea of like having her, if she would bend her knees a little bit and push off, it would help me get her back up. But sometimes she doesn't always, do it.
Okay. Okay. Cool. So now we're back to the fall log. We've done the description of the fall. We have analyzed what is every possible risk factor that we can think of, internal, external, and behavioral, that could have contributed to this fall. And now we want to see what can be done differently in the future, if anything. So, with the first one, with strengthening, that one's kind of, self-explanatory. She can do more exercise. She could get physical therapy, which I know she has before. So the idea here is we start to list out solutions to everyone here, and then we think of which solutions at the end we'll do, which solutions do we actually want to implement, if anything. So, exercise to get stronger. We could do a round of physical therapy. Anything else? Has your physical therapist given her any exercises she can do at home?
Yes, home therapy. Yes.
Okay, home exercises. Does she do them?
Not always.
Not always. Okay. So then it's like, yeah. So we just go through these. Age, we can't control anything about age, right? Cognition, this is where it's kind of like the heart attack example earlier, where that guy needed to like do everything he could in his power to take care of his heart and make sure he's checking up with doctors and stuff. So with brain health or with a cognitive impairment, then it's are we doing what our neurologist is recommending? Are we getting follow-ups every year or as recommended? Are there anything that we can be doing in our nutrition and our exercise? Are we could get speech therapy. Speech therapy is kind of a misnomer. They do work on speaking, but they also work on swallowing and cognition. So for people that have cognitive impairment, could we do a round of speech therapy and say, is there anything that can help slow the decline of the cognitive impairment? There's a lot of controversial stuff on nutrition. So that one I recommend either going to a nutritionist or doing your own research. The beauty of 2024 is we have so much access to information age, and you just have to be careful of what information you're intaking and who you're trusting, because nutrition science is all over the place because of what's the word I'm looking for? Mixed motives, conflict of interest. There we go. Is that a lot of the research studies that are done to support eating a certain way, like veganism or eating a carnivore lifestyle or paleo or keto or Mediterranean diet, are funded by people that have that interest. So I just and nutrition is really so individual. So a lot of it comes down to like, how does your body function best with what you eat? So it's about getting more body awareness, getting in touch with, oh, when I eat this food, oh, I thought it was helpful for my body, but I noticed this trend with it. So it's kind of experimenting and listening to your body very closely with that. But there are recommendations. I will say the common denominator of all of the recommended ways of eating is whole foods. So less processed, the better. And that really, really is true for brain health. So if someone with a cognitive impairment, wanted to do something about that one, maybe they could look at adding more whole foods to their diet. Okay, urgency of urination. This one could be setting her up on a bathroom schedule, or it could be there are therapists that specialize in pelvic health. And so it could be doing a few sessions with a pelvic health therapist to say, hey, why is it so urgent? And is there anything we can do about it? So that could be something that we do there. And then balance, we can do balance training. Kind of, we talked about exercising, gait, practicing walking. So the only other thing I would add would be like increasing overall level of activity and increasing opportunities for her to walk. So increasing physical activity overall, and then increasing walking time every day. So then we'd go down to lighting, so we can get a better light. That one's easy. And that one's a quick fix, or a quick improvement rather. Barefoot, so we talked about supportive shoes. Add a footstool that could be 4 to 8 inches. The other piece I'm going to put here, Mary, caregiver training, which I know you've done before with the therapists that have come in, but that's a lot of our role as therapists, is training you how to instruct her. So if you know, okay, this is the sequence that works for us, and you instruct her, especially if she does have a cognitive impairment, if you instruct her in the same exact way every single time to make it just, this is
Consistency.
always the way that we scoot back. First, we put on the shoes. Then we bring the footstool. Then I tell my mom to put her hands on the armrest. Then, and so making it just there's one way that we scoot back in the chair, and we do it that way every time. The other thing is to make your instruction as simple as possible and as few words as possible. So I challenge myself to this when I'm working with my clients. I challenge my caregivers to practice this. I shouldn't say challenge. I practice this is trying to keep my instructions 5 words or less. So it would be like, put your hands on the armrests. Put your hands on the armrest. So that was 7 words. But typically, what I tend to do is, okay, Mary, we're gonna scoot you back in the chair. We're gonna do this, and then we're gonna put your hands on the armrest. Okay, and I just launch into way too many words and add unnecessary words. So if you're being very intentional about, okay, put your feet on the stool. Give her time to do that and be completely silent. It's hard to do at first. And then, okay, put your hands on the armrests. Okay. And then you go in and grab the towel. Okay. We're going to scoot back. I'm going to count to 3. Ready? 1, 2, 3. And then you both effort together. So I have found the fewer words as possible to be less confusing and more effective. So we'll put caregiver training, come up with a find ideal sequence to help my mom scoot back in the chair and do it that way every time. And then you can count to 3 so that you're both working together. You can use as few words as possible. Okay. Anything else that you can think of for the external bucket that we could potentially, we're just brainstorming here.
No, these are all really good suggestions. Just to add, like I try to motivate her sometimes, like,
Okay.
if she does, she can have a cookie or she can have a, positive reinforcement or some, just to keep it, just to kind
Yeah.
of keep it interesting for her.
Okay. Dangle the carrot. So
Dangle the
rewards.
carrot, yes.
Rewards are great. I definitely have told patients to do that. Like, I've literally told patients, like, give yourself a reward after you do your exercise routine because you haven't done an exercise routine. This is all new to you. So it might take some kind of cheerleading, self cheerleading, and pepping yourself up and rewarding. So that is a good idea. Okay. And then we sort of touched on this lack of physical activity. We touched on that up here. And then finding out, a hydration solution. Um, does she like water?
No.
Okay. Have you tried other liquids that are not coffee?
You know what? I sometimes I offer watermelon. She
Okay.
loves
Yes.
watermelon.
Yeah. Foods with water. Great. Great. So that's a really good idea. Um, there's mixed, I think it's mixed. I have mixed feelings myself about, a while ago I heard, oh, it doesn't matter if the person's getting the recommended amount of water every day. They just have to get, like, say it's eight glasses of water a day. Or I've heard half your body weight in ounces. It doesn't matter if you're um what the liquid is, basically. If they're drinking juice, just as long as it's not something dehydrating like coffee. But if it's juice, herbal tea, little electrolyte mixes, Gatorade, whatever, then 8 glasses of any liquids is better than nothing. So if the person absolutely hates water, there's a lot more options that way, and it feels a little more accessible. The where I'm conflicted is that a lot of juice and Gatorade in particular have a lot of sugar. So then that kind of goes against the nutrition piece. But um, anyway, there we are. So I'm not going to put you in the hot seat anymore. Thank you for
You're
volunteering an
welcome.
example. And then what I would do with a patient is to work through this and say, are any of these feasible? And really say, try to simplify it because this is a lot because we're doing a thorough assessment of one event. And then you can say, well, I really want to be more consistent with my home exercises, and I think I'm gonna try the footstool idea. So then you kind of pick what's most doable initially. Um, and then yeah, so that is working through the fall log. So I do recommend that everyone keep a log of falls just so you have. I would recommend that if you haven't started one already with your mom, that you just document it. It doesn't even necessarily need to be this thorough if it's like every time she slides, but I think it's helpful to just see trends because you can see, is she always falling at 6 p.m.? And maybe that's not information we would have found out otherwise or um, whatever. So that is the fall log. And then we'll just quickly go through what you can do about it here. So educating yourself, you're already doing that by watching this video, by being at this webinar. There's also longer, like I was mentioning, there's these very comprehensive fall prevention classes that usually go over 8 weeks, and they talk about all of these risk factors very in depth. So education really helps with prevention a ton. Okay, keeping a fall log, we talked about that. And then I put take action. So you want to notify your family, your primary care physician, and your physical therapist. You also want to take action. So I used to do this thing where I would like keep a lot of data, but then I wouldn't actually take action on it. So I realized, why am I keeping this data if I'm not going to take action on it? So, excuse me, if someone is living their life and they're falling and they're not interested in learning how not to fall, then they wouldn't probably want to keep a fall log because they're not really prepared to take any action. So don't just collect data for sake of collecting data. Collect it if you are prepared to kind of take action on it. And then do a round of PT. So this can increase your balance and decrease your fall risk. And then a physical therapist, especially one who that's really become their niche, that they really work with a population that falls a lot, especially as I've gotten more and more into fall prevention. I treat a lot differently now than just to the general population of 65 plus. So looking for someone who has a special interest in that area can be really good, and having them do a thorough fall risk assessment on you and making a plan to go forward. Okay. Lastly, just to touch on fall prevention and what that entails, because I keep saying, oh, there's so many risk factors that put you at risk of falling. It's so robust and comprehensive and stuff like that. So when you look at all of the fall prevention recommendations in the US and globally, all the ones that I could find, at least, they all start with exercise, home safety, medications, and vision. This is a good starting point. And most of the people that come to me already know that they're at risk of falling, and they already know that they don't do the recommended amount of exercise. So that's usually one of their goals. And then consistency, so that use it or lose it, that's where this comes in. So even myself, really at any age, if I stop exercising, I'm going to lose the strength that I have right now. So that's kind of a universal truth. Um, and I tell people I would rather you exercise twice a week and have it be consistent for the rest of your life than for you to come work with me and get so excited and you go all out for 2 months and then you stop everything and then lose it. So consistency is super important, um, with strength and balance. And then home safety, there's occupational therapists that can do a home safety evaluation if you're looking to age in place, if you need any home modifications, for example. In the context of physical therapy, I do a lot of home safety education just because this has become the area that I love to work with. Medications, getting those medication reviews and getting your vision checked every year. And then, of course, if you have any that you know about, like, um, I'm thinking if someone has like a foot amputation or something, then if something is really putting you at an increased risk of falling, or say every single time that your mom falls, it's because she has that urgency of urination and she's trying to run to the bathroom. Well, then we need to, in her plan, move the solution for the incontinence up in the priority list. So it is very individual, but just on a general scale, when we're looking at fall prevention programs, this is a good place to start. Okay. So, do you have any questions? I know that was a lot.
No, I thought it was good. I found working through the fall log was very helpful.
Okay. Okay. Awesome. Awesome. Cool. And I can send that to you if you'd like.
Sure, sure, that would be
Um,
great.
cool. Cool. Well, thank you so much for coming.
You're welcome. Thank you.
Yeah, you're welcome. You know how to reach me if you do have any questions.
Okay, take care, Amber.
All right.
Thank you.
Take care. You're welcome.